So how is Bangalore?
Yeah, it's good actually. Weather is
Mhm.
pleasant.
Weather is
We are
pleasant.
expected to have rain still mid of October.
So, very good evening, one and all. Very good evening, my dear peers, my seniors, juniors, and to all the doctors who have joined here today. As you all know, we are here for an academic feast that is to follow. From your practice perspectives, there is not something more that I need to add. Diabetes is very common in India, with ICMR INDIBE saying that we probably have more than 101 million patients with diabetes. Later estimates showed much more. When we look at the entire cluster and the entire gamut of non-communicable diseases, we also have a threefold increase in hypertension. So what we have is a metabolic clustering of cardiovascular risk factors with diabetes in our patients. It becomes important as we understand the management of diabetes to keep abreast with latest trends so that we can empower our practice to the next stage ahead. On the same accord, recently the EASD Congress just concluded in Vienna, Austria, uh, and to share not just updates from the same, but clinical caveats and takeaways for what can occur in Indian clinical practice. We have some of the greatest minds from the country and the best of teachers. I have the honor of introducing both of them. So at the outset and the start, we have Professor Dr. Mangesh Tivaskar, sir. And I have to say this very candidly. Uh, it gives me goosebumps to just introduce my teachers in front of you. Next slide. Ms. Mohita, next. Yeah. So we have none other than Professor Dr. Mangesh Tivaskar, sir himself, who needs no introduction in the field, but nevertheless, I'll do the honors. He's a consultant physician and diabetologist at Shilpa Medical Center, Mumbai, the editor-in-chief of JAPI, the former General Secretary of the National API, and he's been on the editorial board of the Medicine Update IJT. He's been a guest editor to multiple journals. He's had more than 157 publications in peer-reviewed national and international journals. Not just this, ladies and gentlemen, a lot of his work is also cited by international international bodies. He's a recipient of the prestigious Professor Dr. Lionel OP Fellowship, DRC London. He's also an MRCP examiner, and also he's been a gold medalist in his MD medicine during his MBBS days for biochemistry, pathology, microbiology, and pharmacology. Uh, it's an honor to have you, sir.
Thank you, Partha. Good evening, everybody, and wish you all a very happy Navratri. Thank you for wonderful
Thank you,
words
sir.
of introduction.
Thank
Actually, you
you,
should have said that I am just one line introduction, that I am a colleague and a follower of and a diehard fan of Dr. Ganpati Bantwal, and that would have been enough.
Thank you, sir.
sir. It's uh, also an honor to have Professor Dr. Ganpati Bantwal. Again, needs no introduction in the field of endocrinology or diabetology or medicine. Uh, Sir currently is the professor of endocrinology and the former head of St. John's Medical College, Department of Endocrinology, St. John's Medical College, Bangalore. He served as the past president of the Endocrine Society of India, the past treasurer of the Karnataka Endocrine Society, the past secretary of the ESI again, past secretary, vice president of the ESI, the past joint secretary of the Karnataka RSSDI. He has over 100 publications, again in national as well as international journals, and is a principal investigator to more than 80 clinical trials, ladies and gentlemen. Uh, I'm quite sure this is a very short introduction. There's much more I can go on saying, but in the interest of time, I think I would hand over to our first speaker, Professor Dr. Mangesh Tivaskar sir himself.
Thank
Sir,
you.
over to you.
Thank you. Thank you, Dr. Parthasarthi. Thank you, Ganpati sir. And of course, entire DocMode team, and good evening, viewers. Thank you very much for this wonderful opportunity. As I start the session, let me have a pleasure and privilege to wish you all a very, very happy Navratri and a festive time. Friends, last week in Vienna, between 15th of September to 20th of the 21st of September, or rather I would say 20th of September, 19th of September, 61st EASD happened. And we both, Dr. Ganpati and me, had a privilege to be a part of that conference in various responsibilities. And I'm going to present to you in very short, coming up 20 minutes, about the contemporary approach, which were primarily discussed in that couple of new presentations which had happened, and some interesting discoveries that have been presented during this 61st EASD. So let me start with my first slide, and that is, from the Diabetes India Satellite Symposium that was on 15th of September, which happened at Vienna Convention Center. Let's discuss about what was discussed there as far as the diagnosis of diabetes, the epidemiology, and the disease progression of diabetes. Now, friends, we all know that Southeast Asia, and especially China and India, they form the epicenter of diabetes and dysglycemia. In Asia, 60% of the global diabetes population habitates. And it is very interesting to understand that in India alone, there are more than 107 million people with diabetes. And these numbers are mind-bogglingly increase. Now, if you put both diabetics and pre-diabetics together, I would say it would be the third largest populated country in the world if we put the pre-diabetics and diabetics from India. So that is the impact of, and that is the onslaught of diabetes in our country. And that makes us to, count or to say that, it's every 1 in 7 adult individuals have diabetes, especially. And in India, the numbers are just mind-boggling. What is more concerning is this, that every 1 in 3 live births are affected by hyperglycemia in pregnancy in diabetes, and especially in the Southeast Asian population, and especially the Indian mothers. And hence we have to understand that this is the disease which is taking the toll. And this has been very well elaborated in this Diabetes India Satellite Symposium that happened, which was, actually hosted by Professor Dr. Banshi Sabu, and the speakers were Dr. Banshi Sabu, Dr. Sanjay Agrawal, Dr. V. Mohan, and entire team of Diabetes India. What was most prominently brought out in that was that the diabetes related expenditure in this Southeast Asia zone is $12 billion annually. I am really mind blown, because if you look at the Indian GDP and the amount that we invest in taking care of our diabetes and the chronic metabolic sector, it is just minuscule. And in comparison to that, the amount of the money that is spent on managing this disease and its complications is outstandingly concerning. So Asian population is at the higher risk. We all are aware about it because of his high insulin resistance, low BMI, but still very high fat content and high central and visceral obesity. That proposes that, that we are very well highly ethnically driven population for development of diabetes. So let's understand the progressive nature of diabetes. And there were some very interesting studies which were published. First was the data of pre-diabetes, as Dr. Parthasarathi was talking about. We have got high number of pre-diabetes, around 153 to 160 million people. But what is the most challenging thing is this, that they convert from pre-diabetes to diabetes very fast. So our people don't stay diabetic for a long time. They get converted very fast. And hence, very interesting statement was given that there is nothing like pre-diabetes. There is nothing pre. Even though you have got just simple impaired glycemic tolerance, you are almost certain that over a period of time, if you are Indian, you are going to develop diabetes very, very soon. And Dr. Mohan presented this, that, it's high time to be a little more proactive, to pick up these patients, to try and attempt to halt the progression of pre-diabetes to diabetes. And from there, what came an idea of what is called as an earlier detection and prevention strategies for diabetes, because we all know that it's up to pre-diabetic or earlier days of diabetes, the diabetes can go into remission. I may not use the word reversal, but I definitely can use the word remission. And it's very interesting to know that one interesting investigation which has come up very prominently in this Diabetes India Satellite Symposium was 1 hour plasma glucose as a diagnostics tool. And this was again talked by Dr. V. Mohan in his presentation there. And this is an idea of position statement that they have now started understanding the importance of doing a 1 hour plasma glucose level post OGTT. And the cutoffs for the impaired hyperglycemia is more than 155. And if the sugars or the blood glucose is more than 209, then probably you need to work up these patients for diabetes and the further related investigations. So this is what the proposed cutoffs are. 1 hour plasma glucose more than 155, it is intermediate hyperglycemia, which will call for immediate lifestyle intervention or diabetes prevention program. In fact, I will say that, we should not be even waiting to develop this, dysglycemia. Lifestyle intervention has to be the part of our day-to-day routine life, whether you have diabetes or whether you have dysglycemia or not. And then, but somebody has a blood glucose of 209 and above, then we'll have to repeat the test properly, fasting prandial and A1C to confirm the diagnosis, and then full evaluation and the treatment. So the proposed algorithm for all OGT tests should include 1 hour sample. So it's not 2 hours just, fasting and 2 hours. No, start doing 1 hour glucose sample also, because that will definitely optimize the prediction for diabetes as well as the augmentation of the cardiovascular risk. A DCLIP trial was presented as an Indian diabetes prevention program, and where they looked at the importance of progression of impaired glucose tolerance and the role of metformin or the drugs like pioglitazone or alpha glucosidase inhibitor during this Diabetes India symposium. And the international and the Indian guidelines. And Dr. Ganpati Bandwal was also one of the writers of the RSSDI 2022 along with me. And when we wrote about that recommendation of lifestyle interventions, that is diet, physical activity, and healthy habits as the primary strategies for the individuals, those who are at the higher risk of developing diabetes. Now, when lifestyle modification fail, then probably you have got to do the pharmacological intervention, and still the drugs of choice, especially in the Indian subclass of the patients, because of the high insulin resistance, are metformin, pioglitazone, and acarbose, as advised by the guidelines. ADA 2025 also seconds this recommendation from RSSDI 2022, where they say that if the patient is aged between 25 to 60 with BMI of more than 25 kgs, and if the fasting glucose is more than 110, or if the A1C is more than 6, or the patient has a previous history of gestational diabetes, these patients are likely to progress to develop diabetes very rapidly. And these are all the patients who would call for immediate lifestyle intervention and give 6 months of time to them. And in scenario where after 6 months, if the interventions of lifestyle modifications, they fail, then you must initiate these patients immediately to the pharmacotherapy, and the drugs like metformin, pioglitazone can be easily used. Also, they propose that also all the impaired glycemic tolerance patients should be screened for the possibility of now not NFALD but MSALD and the possible cardiovascular risks. And especially in those patients, those who are overweight and obese, you need to really initiate the weight reducing therapies or weight loss medications. And in morbidly obese patients whose BMI is more than 35, they should be submitted for the discussions for the bariatric surgery. But pharmacotherapy with metformin or alternatives, they remain still the first choice of the therapies in all such patients. Now let's come to the new therapies, which was a very interesting Swedish discovery, national data registry, which was presented. Now they looked at the new therapies and how safe it is to go for a tight A1C control. And this was almost a decade old data that they have looked into type 2 diabetic patients. All type 1s were, ruled out. And they collected the patients, those who are more than 18 years old, from the National Data Registry. And from January 2008 to 31st December 2017, the patients were looked at, and there were 3 groups of the patients, those were analyzed. Very tightly controlled early. That means that the A1C of less than 6.5 at all the visits. Then the second group was not early tight control. That means there were a couple of visits where A1C was more than 6.5, and early adverse control visits. That means that in all the early visits or on all the visits, the A1C was more than 7. And they looked at 3 things: the microvascular complications, macrovascular complications, and cardiovascular death. And you can clearly see from your screens that those who had an early tight control had much lower incidence of both micro and macrovascular complications, but also much lower incidence of cardiovascular death, which was statistically significant. So the key insight is this, that when somebody is diagnosed with diabetes, especially in the early days, initiate very tight control and insist and see to it that the patient receives that kind of therapies to achieve A1C of 6.5, not only just achieve, but try to stay there as long as possible. One very interesting study of combination of metformin versus and dapagliflozin combination in roles and their roles in the type 2 diabetes management. We all know that now, especially with the advent of SGLT in last decades, the way we manage our dysglycemia patients have changed completely. We all are aware that diabetes is the cardiometabolic chronic disease driver, and it's a very high risk for the cardiovascular renal challenge and the metabolic challenge. And we know that, especially in India, the disease outcomes are not only just determined by the food we eat or the lifestyle that we have, but there are social determinants, cultural determinants, and ethnicity determinants. But what is most interesting, and this is a very interesting thing which has come out in this EASD, was that metformin was still continued to be one of the excellent early interventions, despite of all the things which have been talked about. And these are IDF 2025, ahead of publication releases. And you can clearly see that whenever there is a basic care which is necessary, generally metformin still is the first drug of choice. Of course, when somebody is at the high risk of developing atherosclerosis, cardiovascular disease or heart failure or a renal involvement or the possibility of ASCVD or obesity, then maybe probably the SGLTs or GLP-1, according to the recent ADA guidelines, we continue to stick to that. So the standard management principles, according to IDF 2025 guidelines, which are lifestyle plus metformin as a first line in all the groups of the patients, try to initiate that and then go for an early combination therapy at the first indication with either an SGLT2 or a GLP-1 or both, depending on the patient's profile, and then early intensification to achieve the tighter glycemic control is very, very important. An interesting paper was presented looking at the epicardial adipose tissue, that is EAT, as a key mediator for the coronary microvascular dysfunction. And this was what called as a DAPA heart trial. This was a 4-year-long study. And what they found out that SGLT2 inhibitors like dapagliflozin had a terrific effect as far as the epicardial adipose tissue is concerned, which is responsible for the most important outcome. That is, they have looked at the epicardial fat thickness, and they also have looked at the flow reserve, the cardiac flow reserve, CFR. And what they found out that when you initiate somebody on with dapagliflozin in DAPA heart study, which was a 4 years clinical experience, they found out that the cardiac flow reserve improves and epicardial fat or epicardial adipose tissue, which is the driver of a cardiovascular event, both micro as well as macro, but primarily microvascular cardiovascular event, where you cannot have an intervention, right? Dapagliflozin does a fantastic job by reducing down epicardial adipose tissue. Why this does that? It has been found out that it's just not LDL reduction that dapagliflozin does, but along with it, it goes still further in the lipid metabolism and modifies the way very low density LDL1 catabolism happens, which is also one of the predeterminants of LP lipoprotein little a or LPA, and also it involves the lipoprotein lipase mechanism, which is classically involved in what we get in Indian population as diabetic dyslipidemia triad. Lastly, I'll talk about updates on diabetic foot ulcer. A very, very interesting study was presented, and they found out the trends of the individual's experience in the recurrent diabetic foot ulcers and what are the risk factors. They found out that, the foot ulcers are also very common in the Indian subclass of the patients, but diabetic foot ulcer burden also is one of the key determinants, not only for the mental and the diabetic health, but also to the quality of life, anxiety, depression, but also it is one of the indicators of the cardiovascular challenge. Why? Because they have found out that the triglyceride glucose ratios or the FIB-4s are also extremely high, and the indices are very high, suggesting that there is a background inflammation and metabolic degradation which is going on when somebody develops the repeated diabetic foot ulcers. And survival rates, they markedly improve when you attend and I actually treat these metabolic challenges along with the diabetes management. So when they were managing that, there was one data which was published, which was called as a diabetic foot, initiated antibiotics, and they found out that antibiotics like ceftazidime and amoxicillin clavulanate, they, irrespective of the macrovascular challenge, adequate microvascular circulation is also important. And whenever you initiate these patients on with these antibiotics, they have been found out to be very effective in managing the diabetic foot infections. They reduce down the hospitalization because of the diabetic foot and also reduce down the foot amputations. Malnutrition is not the primary determinant, they have said, but it is the metabolic challenge, which is the primary determinant of the high risk diabetic foot and the outcomes. Last line is the predictive value of PCOD, and we are all aware about it. But this was again, they have reinsisted the fact that do not ignore the presence of PCOD, because PCOD, all these patients, those who have PCOD are at the high risk of diabetes, and we are all aware about it. But this was again reinsisted because they have shown that somebody who has a PCOD have higher chances of developing mortality and morbidity and microvascular challenges in diabetes. So these were some, I would say, updates from the 61st EASD. Now I hand it over to my mentor, my guru, Professor Dr. Ganpati Bandfal, to take it from here. Thank you very much, sir.
Yes, thank you, sir. Great lecture. I don't know how will my lecture be.
It is going to be as equally.
Before I start, let me thank Doc Mode, Dr. Parthasarathi also for the great introduction. Able to see?
Yes, sir.
Okay, fine.
Yes, sir. Yes, sir.
Right. Fine. So I'll also, as Professor Mangesh told, so we were a part of this EASD, the 51st EASD, which happened in Vienna. So I'll also speak on what are the new things which happened there. So I think the burden of diabetes already been done by Dr. Mangesh. So I won't go much into that. Just to reiterate the fact that according to the Lancet Diabetes Endocrinology, we have around 101 million people with diabetes. What's more important, 136 million people are pre-diabetic, waiting to become diabetic, and they have the same risk factors also. So totally we have around 236 million people with dysglycemia. And we are still number 2. Maybe we could overtake China in terms of this. So there are a lot of limitations of the current therapy. So let me. So one of the limitations include, just a second. Yeah. So OHS address only the select components of the underlying pathophysiology and provide the incomplete correction of the disease. 1 second, just a minute. Bipul? Yeah. Yeah.
Isn't it?
Yes. This होता है see this.
I think you're going ahead, I believe.
Yeah, okay, fine. No, nothing. Sorry. Some technical glitch. Okay.
No
So
problem.
coming to the limitations of the current therapy in diabetes management. So as I told you, OHS address only select components of the underlying pathophysiology and provide incomplete correction of the disease process. And then what's happening is we also say if you're using SUs, we are flogging a tired horse. Initially, there will be restoration of the insulin sensitivity, but because of the progressive nature of the beta cell functions, what's happening is you are actually flogging a tired horse. So then actually it doesn't work well. And that is the reason we find that as the duration of diabetes increases, you're not able to just bring down the blood glucose with these medications. We'll have to add medications which is acting on other type of pathophysiological aspects. We also have the conventional insulin regimens, so like the human insulins, but then there is a problem with that. That's because it's not physiological. We'll have to wait for half an hour and then you inject the injection, wait for half an hour. So this is cumbersome. Many people cannot act. And then they overact. Say you are using a human insulin, it will act postprandially more than what's required and can produce late postprandial hypoglycemia. And because of this, what happens? There is a defensive snacking. You eat more, obesity increases, hyperinsulinemia, worsening of insulin resistance. So now the concept of diabetes management has changed from actually just glucocentric to cardio-renal metabolic liver centric. So that has been the thing. So we call it as this as a holistic approach for management of diabetes, and we'll have to individualize the goals also. So till 2007, we always used to think that any drug which reduces blood glucose also reduces the cardiovascular outcome till the rosiglitazone controversy came. And then after that, it was mandated by the FDA that all drugs should have a cardiovascular outcome trial. And then from 2015 onwards, we found that we had a superiority. So these drugs not only helped in bringing down the HbA1c, but they also did have a cardiac benefit and they also had a renal benefit. And of late, you find that they are also having some liver benefits and of late also a reduction in peripheral vascular artery. So the therapy right now is not just glucocentric. Now it is cardio-renal metabolic centric. And to add new to that is liver centric also. And also for that matter, peripheral vascular centric also. Dr. Mangesh has already told about the medications. We do start with metformin and lifestyle, but then the second drug of choice after metformin will be whether they have an ASCVD risk factor or not. And if you have an ASCVD risk factor, then you will use a drug which is beneficial for that, like a GLP-1 receptor agonist or an SGLT2 inhibitor. And if you have also if you have a renal involvement or then say you have heart failure, etc., then the number one will be the SGLT2, and then you can actually use a GLP-1 receptor agonist. More so if you have a preserved ejection fraction. And when you have a reduced ejection fraction, the choice of drug will be mainly an SGLT2 inhibitors. So we are gone from glucose-centric to cardio-renal metabolic centric. So this is how the paradigm has changed. So what will be the future? So now what are the other targets? So now the other targets could be pan-PPAR alpha and gamma. GIP and you have seen that you have the tirzepatide, which is acting on the GIP and the GLP also, which is a dual twin creatine, we call it as. There are some drugs which are working on the G protein coupled receptor 119, and then you have the fatty acid ones, the melatonin, etc. These are the ones which are coming. And the future ones are the 11 beta HST type 2 inhibitors, because that's the one which will see that you are metabolizing cortisol to cortisone. So you enhance that so that the cortisol, as you know, is it's hyperglycemic. So you act on that. Maybe your abdominal adiposity also comes down, and then gene therapy, etc. So this is what has happened from the ADS 2025 standard of care. So as I told you, look for any ACVD risk factor or heart failure. If you have this, use either a GLP or an SGLT2 with known beneficial effects. This is how the evolution of anti-diabetic drugs and insulin has happened. So you can see 1921 insulin was discovered. We are already had 100 years of insulin, and that continues to be there. Insulin can never be replaced, and I always tell that whether you have type 1 diabetes, type 2 diabetes, any type of diabetes, insulin can be used in all type of gestational diabetes. It is a drug of choice. And then, of course, metformin, though it came in 1959, the FDA approved only in the 1990s. That is when the FDA became enlightened. So we were all enlightened before that, but then they were enlightened then. And then we had the acarbose, the long-acting, and now we have come to the twin cretins, the tricretins, where you have, in addition, you have the glucagon receptor agonist, and then you have the pumps which have come, the Minimed 780G, and of course others are in the pipeline. Then you also have the the GIP receptor antagonist, that is the Meridibart, which is coming, and once a month GLP-1 and GIP agonist have come actually. So the future is actually good. So we will be using drugs which will target the root cause of it. So that's how it's going to be prevent diabetes, prevent the development of obesity itself, so that you don't get diabetes. So that's how it is, especially for type 2. I'm not talking for type 1. Coming to some emerging and innovative therapies in diabetes management, as I told you, tirzepatide, GLP and GIP, which is very effective, significant weight loss to the tune of 21% weight loss. And in fact, after the introduction of these molecules, the incidence of bariatric surgeries have come down by around 23%. And then you have this, as I told you, the 3G, the triple GIP, GLP, and glucagon agonist. They are also there. Retatrutide, phase 2 studies have already been done. And then you also have sotagliflozin, which is a dual SGLT1 and 2. Canagliflozin also has some action on the SGLT1. What is SGLT1? It's the one which we use for ORS, what we use for diarrhea, is actually acting via the SGLT1. So the sotagliflozin dual one, it acts on the gut and kidneys for stronger glucose control and cardiorenal benefits. So what are the potential areas of new agents? So one, acting at the level of the intestine. Beta cells try to reduce apoptosis, increase neogenesis, and then you have insulin antagonist reduce that by giving glucagon, decrease the blood lipids, increase glucose excretion. Then you have the insulin action enhancers, the direct metabolic modulators, which can reduce gluconeogenesis, glycogenolysis, etc., and which decrease adiposity. So tirzepatide, as I told you, a combination of GLP and GIP. So why is it important? What have we heard till now? We thought GIP is an obesity hormone. And when you're actually giving this along with the GLP, it's acting better than GLP alone. In fact, the weight reduction is better compared to GLP-1 alone. And one of the proposed hypotheses is what is known as a biased agonism, by which it's making GLP act still better. So this is one of the proposed mechanisms. As sotagliflozin, I told you, acting at both the levels. So it has been found to be very useful in CV outcome trials. Also, you have the soloist trial where it has been found it's useful. The other drugs include glucagon receptor antagonist. You have which act by blocking the hepatic glucagon receptors, decreasing gluconeogenesis and hepatic glucose output. They are the numbered ones. What's the advantage? Improved MAFLD, lipid regulation, weight regulation. Similarly, GPR119 agonist, they are acting at the level of the gut, and then they also improve fasting, increases GLP, reduces weight, etc. Imiglivin is another drug which has come now. This is a drug which acts at the level of the mitochondria. So the mitochondrial dysgenesis is regulated by this, and via that it is acting. The inhaled insulin actually is coming shortly. It's coming to India. It's already there in the US. So it's maybe by next month we should be having this molecule. So advantage is it will act more rapid than the short-acting insulins what you have. Like you have the insulin aspart or fiasp or your Humalog or the Lumjev. It's faster than that and more shorter duration of action also. Acts within 12 to 15 minutes, and the duration of action lasts just 3 hours, almost being more physiological. Of course, you cannot use it in patients who are smokers or who had lung problems. You cannot use it. Teplizumab actually has been used in type 1 new onset to see that. See, when you have a type 1 diabetes, there will be some amount of, at the onset of diagnosis, you'll have at least a little bit of insulin reserve. That means to say the destruction of the pancreatic beta cells has not been 100%. By giving this, actually, we are trying to preserve those 10-15% which is still there, and hence you are actually delaying the insulin dependence. A little bit of even C-peptide present actually reduces complications. Insulin icodec, this is a once weekly insulin. It's been approved only for type 2 diabetes, has not got an approval as of now for type 1 diabetes. So what's the advantage? You are actually reducing the number of pricks. So instead of taking daily, now you're taking only one single injection. It's acting like a basal insulin. And you also have Aspitora Alpha by Eli Lilly. That's also in phase 3 trial, still not got an approval. So maybe shortly it should also get. Retatrutide is triple one tricretins. So where it's acting on the GLP, GIP, and glucagon. Significant weight reduction also has happened, and the side effect profile is similar. Orforglipron is a small molecule, which is oral GLP-1 receptor agonist, and recently, just I think last week, published in the New England Journal, A1C reduction up to 2.1%, and they have compared it with even semaglutide oral. It's doing better, weight loss of around 12%. And cagrilintide, the amylin agonist, has been used. It also helps in further reducing, especially the HbA1c. And they have actually combined it with semaglutide, where we call it is as the cagri-sema. So there are a lot of other ways by which drugs which can act on pancreatic insulin release. Of course, we had the benzamide or derivative, the ripaglinide, nataglinide. They are there. Of course, we don't use it more often because we have other drugs which is acting better than that. Then GLP-1 and its analog exendin 4, the alpha-2 adrenal receptor antagonist, phosphodiesterase inhibitor, etc. Glitazones, of course, are there. It's coming in a big way. IRIS trials showed that it is useful in patients with, it's very helpful for cerebrovascular events. And also the ADA-EASD still says you can actually use it in patients with MAFLD and MASH. So it's one of the drugs which has been approved for use in MAFLD and MASH. So acting via the PPAR alpha and the gamma. Small trials on berberine ursodeoxycholate, well safe, well tolerated, significant glycemic and cardiometabolic improvements in type 2 diabetes were inadequately controlled. A1C reduction not that great actually, up to 1.1%. As I told you, orforglipron just recently shown up to 2.1% reduction in A1C, 12% reduction in weight also. And then the same thing, another trial where they found that phase 2 trial, which is oral GLP-1 receptor agonist, unnamed ones, once again showing that it can actually reduce the A1C to the tune of even 2.6 when you're using an HbA1c more than baseline HbA1c more than 8.5%. And you can see body weight reduction of around 2.4. Not great body weight change here, but then it's been useful. Imiglanin has been given in metformin intolerant patients. So this was the one where I told you the A1C reduction is not that great, but this is acting via the mitochondrial dysgenesis pathway, improving the mitochondrial function. So coming to key highlights, the prevalence of type 2 diabetes continues to rise globally with a substantial proportion of cases remaining undiagnosed. The conventional therapies are limited by risks such as hypoglycemia, weight gain, and lack of cardiometabolic benefits. And that was a reason why we are having novel agents which have a benefits on these. They are anti-hyperglycemic. They have a cardio-renal metabolic benefits. The GLP-1 receptor agonists are preferred in patients with ASCVD risk due to the glucose lowering, weight reducing cardioprotective effect, whereas SGLT2 inhibitor provide combined glycemic and cardiorenal protection in patients with heart failure or CKD. A lot of emerging therapies like tirzepatide, which we recently got, dual SGLT1/2 sotagliflozin, the oral GLP-1 or orforglipron, the imiglibin have been found to have benefits in glucose control and weight management. Some drugs like berberine or sodium shown meaningful reduction in A1C, improvements in metabolic and inflammatory parameters, and then investigational strategies targeting beta cell function, alpha-2 adenoreceptor pathways, phosphodiesterase inhibition, and thiazolidinediones, and dual agonists expand future therapeutic option. So the current clinical guidelines endorse the integration of these novel therapies, promoting a holistic, patient-centered paradigm that optimizes outcomes and addresses comorbidities. Thank you for patient hearing.
The future is brilliant. May not be for our generation, but at least coming generation, the future is going to be brilliant.
Yes, agree, sir.
Provided that these therapies are affordable, I think would be a game changer.
Yes, the FDA nowadays is not actually giving approval to a drug which produces hypoglycemia.
Yes.
It's all anti-hyperglycemic.
Yes, yes. So over to you, Partha. Okay, go
Sure, sir.
Yeah.
So we also have Professor Suhas Hirande, who is
Get him as a panelist, no?
Yes, sir.
Yeah.
Sir has already joined as a panelist. Professor Suhas Hirande, sir, we are very glad to have you with us.
Good evening, Dada. Good evening.
To our audience
evening,
who have joined right now, I'm sure Professor Suhas Hirande too needs no introduction to you. He's one of the astute academicians and diabetologists from the very academic city of Pune. So, sir, we are very honored to have you with us. A few audience questions.
Partha. Thank you so much. And it was very engaging to listen to both Dr. Mangesh and Dr. Ganpati. I believe that the presentation was absolutely lucid, very clear, and the newer developments in the field of diabetes as of EASD Vienna recently, they were certainly very well informed to the listeners. Great it was, no question about it.
Thank you, Sarji. Thank you very much.
Sir, just as Suhas Hirande sir said, just few aspects that I would want to say be it for you and for Ganpati sir. I think the most important thing was takeaways that the audience got, the clinical takeaways that the audience got.
Yeah,
so thank you so much.
I'll tell you that this EASD, Partha, was so much packed with so many interesting symposia that hardly happens generally in the international, congresses like this. But this EASD was, one of those memorable ones, honestly speaking.
Wow, that's great. So we've had a few audience questions. With your permission, if we can take them,
please.
And we'll take the opinion of all esteemed panelists on that. So the first question is from Dr. Pranav. He asks, so at the outset, he thanks you for again raising the aspect of taking metformin back on the podium. and talking about metformin from a 2025 aspect. But he also asks, so what about SGLT2 inhibitors in the Indian settings as a first-line therapy?
Yes.
Are we there yet, or is it too premature to make that statement?
So, who should take it? Ganpati sir, me, or Suhas sir?
So we'll start with you,
Okay.
and then.
So in fact, it is already there, and in fact, it is very much there in the Indian guidelines also. In fact, if you really see the recently released RSSDI Endocrine Society guidelines, they are very clear on the take as far as the choice of the SGLTs. Now, metformin is going to probably a part of the therapy, irrespective of the fact that you have now probably started challenging with the newer onset of change in the way we manage diabetes, as Ganpati sir was talking about, that from the glucocentric approach, we are now moved to the metabolic centric approach, the vascular approach, the organ protection approach. There probably metformin does not have, even though it was indirectly been there already, but it does not have that kind of a randomized controlled outcome trial as these drugs like SGLT group of the drugs or GLP-1 are. But let us understand that, before the era of these drugs, metformin was still there and it was still working, right? So we cannot take away metformin as far as, and we all know that it's not just the glycemia or the insulin resistance challenge that metformin addresses. There's so many other pleiotropic benefits that we are still understanding it. It took USA long time to accept this in their therapeutic portfolio, right?
Yes.
But then once they have accepted it, probably it became the champions. Even we were using these bigonides much before the United States have started using it. In fact, UGDP study had done all the bad things to the drugs like bigonide and metformin as they could do it, but then ultimately it turned out to be the most worstly conducted clinical trial, unfortunately. So we are aware about the importance of metformin, but as Dr. Pranav was asking, and I must appreciate his question, that we are there, and in fact we are robustly there. And I'm very happy that with all the efforts of all our endocrine diabetes colleagues, that the message has been very clearly going to even all the peripheries at the remotest possible places in India, where, and with these drugs which have been now being generically available, the cost effectivity has really helped the people to make it a very easier choice as far as the therapeutic interventions are concerned. I'd like to hear from both Ganpati sir and Suhas sir.
I concur with you, sir. Nothing to add. Only thing, just a word of caution being, we'll have to tell them about the weight reduction which can happen,
Yes,
the increase in urinary pollakiuria, what we call it as,
yes,
and then last but not the least, the genital mycotic
yes,
infection.
yes, yes.
So that's one thing which you must always tell them. And how to tackle it also. It's not that, okay, you are getting it, you stop it. No. So you can tell them how to tackle it also. Say you could use candid cream, or you use a fluconazole a few days, and that will help it weekly once, thereafter, maybe for a month or two, which will see that you don't get these symptoms. And then another thing, after a year or so, we do, some patients do also have UTIs also. That's mainly because if you try to hold the urine, then that's when the problem starts. Don't hold it. Select, the Indian type of toilet is actually good for these things and all. You don't get the infection. I think our ancestors were really clever. So they knew what type to be used actually. So the Indian type is actually the best. You don't get this. So whenever you're traveling outside and all, no. So this is the complaint we get from the patients also. So I think these things to be highlighted. Otherwise, a great medicine. Now that it has become generic also, and it's they have found that it's even good for retinopathy also. And there was a trial known as a Dean trial in fibrosis also has been found to be reduced. It's a small trial.
Yes. And in fact, if you remember, sir, now just when I spoke about this DAPA heart was one of those, an establishment of its role in reduction in the epicardial fat.
Yes.
Which was very, very interesting to know. Because initially, if you remember, we only talked about it. Sundar Mudliar used to always talk about this,
Exactly.
the fuel energy and all that.
It's its own article.
Different zone.
In the JCM, he told it's useful for the eye also.
Eye also, yes, exactly. And as far as the genital mycotic infections are concerned, my understanding, if at all, sir, if you use SGLTs as not a glucose lowering agent primarily, but more towards a cardiometabolic protector, which
Yes.
can reduce down the glycosuria load. The higher the glucose and more uncontrolled sugars, more glucosuria you are going to experience. Higher the possibility of developing the genital mycotic infection. So there. And more importantly, as Sir was talking about, we talk very exclusively about the genital hygiene to women, but we have to make it a habit to talk to even men also to follow the similar genital hygiene as we suggest and advise to all our women patients.
Right.
They have to also follow that. Hydrate yourself well, and probably you definitely will be able to successfully reduce down the possibility of the increase in the genital mycotic infections. So, sir, your take, Suhas.
Yes, this is I take it as something which is both ways. Why SGLT not as the first pharmacotherapeutic agent? So people can certainly keep on arguing. Right now, if we use SGLT2 inhibitors, maybe for at least those, forget about the contraindication, obvious contraindications, very frail, elderly, pregnant, let's forget about it. The typical case of type 2 diabetes where we use it, let us presume that the person has got no cardiorenal complications. So use SGLT2 inhibitor as a glucose lowering agent inadvertently without a workup, because workup is not possible for a lot of patients for varied reasons. Most importantly, the time constraint from the physician side, availability of all the relevant investigations, maybe the NT-proBNP or CD heart for the heart failure aspect, or maybe the renal things. So if in the absence of workup and not registering a cardiorenal complication existing, if we use SGLT2 inhibitors with metformin, let us say, as a anti-diabetic, oral anti-diabetic treatment, okay, we can say that in Ganpati sir, in Marathi, we say that it is a gajarachi pungi. So it's a carrot. If you like it, okay, you can eat it. If it is used as
If
a,
it works, it
let's say,
works.
flute,
Otherwise,
well,
we should
yes,
avoid
you have a
it.
double benefit. So that way we can look at it. And of course, the very clear-cut instructions, weight loss intimation, the glycosuria, genitourinary mycotic possibility, all these, they have to be on board, maybe written or maybe in a separate pamphlet form. But the advantages, the cardiorenal protection is so vehemental now, so much documented across populations over a period of long time, that we shouldn't prevent the people from having these advantages and at a fairly good price now. So that's where I stand.
FPF and heart failure with other challenges, I think this has become one of the pillars of the therapy.
Thank you, sis, for that. Just come to the next question. Sir, our next question comes on the GLP-1 arrays, considering that we already have two new injectable ones available in India, be it tirzepatide or semaglutide. So Dr. Shah asks, key concerns with GLP-1 arrays in Indian settings other than the GI tolerability. How to manage patients who have an asymptomatic elevation in amylase and lipase? What about challenges with sarcopenia? Sir, are they practical concerns? Because considering Indian diet is not actually very protein replete, probably that's where Dr. Shah also gets his point. Dr. Shah also raises a question on the ocular manifestations of GLP-1 arrays, especially from the proliferative diabetic retinopathy perspective, and the NAION, a new side effect that has been generated. We too had read papers in JAMA Ophthalmology published for this year. So Dr. Shah asks a question. So what about these aspects? How to look into and manage? Ganpati sir, maybe you can take this one first.
Yeah, fine. Now coming to sarcopenia, see, whenever you lose weight, you tend to have some decrease in the lean body mass also. Even when you lose weight by diet and exercise also, you tend to lose it. somebody who loses, in fact, they have done studies actually in women, especially starting from, I think, 14 years till 70, 75 years. You lose around 22% of lean body mass whenever you lose weight. And then the same thing they extrapolated and they told is around 25% for men. So what they have found with the GLP-1 and the GIP, what the combinations is, a meta-analysis was done from 29, this one, they found there's a 29% decrease. But if you see the overall fat decrease is there, what you have to tell them is when you lose this, you must do some weight-bearing exercises also. Eat proteins also. In the Indian setting, a lot of pulses they can take, maybe. So that's the one which will actually help them. So of course, in the non-vegetarian side, we have a lot of things to offer. So weight-bearing exercises and increase in proteins. Increase in protein is not great, this one. It is 1.5, 1.6. You can actually go to that. Of course, they shouldn't have any renal problems. Otherwise, you can go maximum up to even 2 grams also. You can go for that. That's a maximum. So you could go for that. So that's one aspect. A second aspect about the worsening of proliferative, see, that happened in the DCCT trial also. So in the DCCT trial, they actually found this. Uh, this happened, the DSMB met. What's this intensive therapy? Glucose is coming under control. And you find worsening. They thought, okay, next visit we'll stop it. And then they start noticing that it actually halted and they started improving. So this is what happened in the DCCT actually. The same thing here because of the rapid decrease in the A1C with these drugs. So probably that could be the reason. So maybe we will not be so aggressive. That could help. Or if you have somebody having more severe retinopathy, you actually can laser them, stabilize it, and then you can give it. So that's another option. Yes, now this NION, that is a bit difficult. It's very rare. We don't know who is going to get. Nobody knows what it, how it is coming, all those things. So there's no answer for that. It's a bit difficult to prove. Is it the cause? It's like this is all. For example, you had Alan Brunette producing esophageal cancer. They told based on the data from Medicaid. How can any cancer happen in 2 years? Is it similar to that? So we'll have to wait and watch. We still don't know. We don't have the right answers as of now for that. Of course, maybe somebody is having more severe proliferative retinopathy, etc. I think we should be a little bit cautious. But overall, what you're happening is you are going to get benefits of these drugs. It's reducing weight, it's reducing MAFLD, NASH, MASH, all those things. Blood pressure comes down, lipids improve, you're more mobile now, osteoarthritis comes down. You're having so much benefit and you have a little bit of this. So we'll have to weigh the pros and cons and then decide. So that's what I can tell about this.
Sure, sir. Suhas, sir, over to you.
Sir, in the view of this muscle loss, naturally counseling will be helpful. And I believe that the ADA 2025, in fact, there was a mention in one of our slides of the drug bimagrumab. So there is a BELIEVE trial which is already successfully presented, small number of patients, but the muscle loss is certainly maybe under control, so to say, rather than not giving bimagrumab. Protein supplements and weight-bearing exercises, very important, no question about it. And the non-ischemic arteritic ophthalmopathy, that is something which is certainly a mystery as of now. But
Yes.
I would say all of us are practitioners. So any which way, and those who are doing the studies on semaglutide, there is a standard requirement that you should have an ophthalmologist on board. And before enrolling the patient in the study, you have to do a fundus photograph and ophthalmic opinion any which way. So if we translate it to our practice, I believe it will be more on a safer side, both for the patient and for us, till the time we really find the answer of whatever is the etiology or can we really prevent it from our point of view, etc.
Thank you, sir. Mangesh sir, over to you, sir.
Yeah, I absolutely agree to both of them. And in fact, sarcopenia is a thing to monitor, surely. You should be sensitized for that, and especially for the drugs, those who can cause robust weight loss, like it has been already reported that the only thing probably on the GLP management which you have to watch for is only sarcopenia, sarcopenia, and sarcopenia. Rest all are very, very rare things which are. And as far as Nion is concerned, there is a little bit of explanation for that. And Nion is little more with isolated GLP-1 receptor agonist in comparison to the twin cretins, basically because of the dual action. And we all know that GLPs have an effect on what we call it as a beta-arretine pathways. And beta-arretine pathways are a little more active in the ophthalmic nerve and the optic nerve. And these are the places where probably they can impact and can cause Nion. But latest today's Medscape, if you can really find out the quiz, and if you do the quiz with Medscape, you will find out that they have asked a quiz question there that tell us about the incidence of Nion, and I wrongly answered this, that it has been seen, and the actual answer was very rare. So in fact, it is more talked about rather than, it is more documented. It was an incidental finding, might be, as we probably had the similar kind of debates about, a lot of other drugs also. So it's just like that. So as far as me is concerned, I'll always say that, any medication that I use is a weapon. It is going to have an effect, it is going to have a side effect as well. Or maybe probably I may not use the word side effect. I would say an effect which probably I do not want it. But that does not stop me from using it if you are smart enough to use it. It's simple as that. If I drive a car on a road, it's quite possible that I might indulge into an accident, but that doesn't stop me from driving, right? If I breathe this air, I might get the communicable diseases, but then I don't stop breathing. This is very important to all of us to understand that. These are the drugs which are going to be there. The drugs are going to have some kind of an effect. There are some going to be effects which are probably not welcomed. But then you should be able to tell the patients that yes, the benefits are far more than probably the risks those are involved. And we'll be vigilant on the risks which are there. So as far as asymptomatic rise of amylase, in fact, that tells you about that the drug is working. Maybe that you have to be watchful, but that you have to be watchful whenever you are using even a DPP-4 inhibitor. And if there are some patients who are going to get this, but that does not, or that should not be a limiting factor for the prescription, right? So that is my take on it.
Thank you, sir. Sir, the last question for the day. MASLD in diabetes. As you all rightfully said, semaglutide is recently approved, the ESSENCE trial. As Professor Bantwal also rightfully said, there was the DEAN trial, though it is not translated immediately to an approval, probably, but it was the first trial to show histological benefits of an SGLT2 inhibitors on regulatory-driven endpoints for MASLD. Sir, also resmetirom is approved in the West. It would probably take quite some time to come to India.
But this time, resmetirom, they had I would say in the industrial area, there was a stall for resmetirom, this EASD.
Wonderful, sir.
I was very happy to see that, that resmetirom is now coming up in a big way. As
I
far as
think
the
in India
management
we
of-
have one drug one company which has brought in resmetirom.
Yes.
In India?
Yeah,
India,
I
sir?
forgot the name of that.
Oh.
It's around costing around 4,800.
4,800, yes, yes.
Oh, okay, sir. So we do understand that these therapies are there in the pipeline, but largely not all of them are maybe immediately available for patients. So in the absence of these therapies, or if it's there, great, sir. I mean, you have enlightened us. What key clinical pearls would you give to our audience for early diagnosis and management of MASLD in clinical practice? Mangesh Tivaskar, sir, first you, sir.
Yeah, so to me, MSLD is as correctly labeled now, metabolically associated steatotic hepatic dysfunction. I completely agree to that. I look at it two ways, One is what, there's a great tool to demonstrate and tell the patient that, look, now you have started getting a fat in the liver. So it calls over your immediate attention as far as the lifestyle and weight reduction change. And also I keep it as a good marker for the possible event and initiation of the therapies. And honestly speaking, with these newer drugs that we have, I'm not too much concerned because you are going to lose fat and you are going to lose weight. You lose weight, probably the the ectopic fat deposition which has happened in all the organs. So organ fat deposition will also go down. See, the challenge is this that, we always keep on focusing ourselves as one of the markers of, inflammation, the metabolic derangement as one of the areas. But then we have got these beautiful drugs. They are going to give you a significant weight loss and you lose weight significantly, maybe around 5 to 10% or even 15% of weight loss. I am more than sure about it that you are going to lose weight from fat from the liver or even pancreas also, or even the other organs as well. So, uh, of course, as we discuss about it, liver fat deposition is not a good thing to have for sure. We do need interventions, and still pioglitazone is one of the greatest drugs that we have. And SGLT2 inhibitors, they are coming in a big way. GLP-1 receptor agonists have been already established in a big way. Vitamin E has been proven to have some effect. So current approval is for pioglitazone, but I'm more than sure about it that SGLTs and GLPs are going to get the approvals, apart from, the rest of the medications. And of course, the future therapies are great. So let's see what happens.
Thank you, sir. Suhas Agande, sir, over to you.
From the early days, I remember 20, 25 years ago, when lots of our ultrasounds were cursorily mentioning fatty liver, which was a crude comparison of the echoes coming from the liver and compared to the kidney echoes. And every individual who was maybe some overweight or obese, his report of sonogram will be saying fatty liver. So that was technically a layman term, honestly speaking. Now converted to NAFLD, then to de-emphasize alcohol, we have now MASLD, etc. The important thing here is if we have terminologies, they are the representatives of metabolic syndrome from the liver aspect, or the other way around. Liver problems are denoting that yes, this is a person who is likely to have metabolic syndrome, so insulin resistance and all other cardiometabolic issues. So from that point of view, anything which reduces insulin resistance, the best of course is physical exercise and then weight loss. But naturally pioglitazone or other drugs which can help remove the visceral fat, like maybe gliflozins, certainly they are going to be important. And the semaglutide recent trial certainly has catapulted it to a position where it is now being accepted as one of the important entities for MASLD. So I believe let us absolutely not forget the initial, which is lifestyle, and try to, let's say, reduce weight, because otherwise the flip side of the coin, we never cannot forget that if these GLPs and all, if they are stopped, then naturally the weight comes back and all the other enemies, they also come back. So from that point of view, we actually need to be more cautious so that we'll pass on that to our patients who are put on these drugs.
In fact, I am in complete agreement with what Suhas sir is saying. In fact, this becomes a one-way track. If you stop these drugs, the weight will come back, but your muscle mass loss, that is not going to come back. And that whole thing is again going to be replaced by fat and fibrous tissue. That is the biggest challenge of these drugs, which nobody talks about yet currently.
Yes,
But
yes.
he has
So the
rightly
percentage
pointed
fat
out.
actually will increase
Yes,
post stopping the GLPs or maybe twin incretins.
yes.
Wonderful, sir. Wonderful.
And in fact, I'm surprised, Ganpati sir, to see that berberine was presented by Chinese people, and we had berberine, for so many years in India. Surprisingly, berberine was presented in this EASD by Chinese people. It was like really surprising, isn't it?
Ganpati, sir, your final words?
The best example, as Dr. Suhas told, today I had a patient whom I saw her around 5 months back. So she had a fatty liver, grade 2. I put her on oral sema, and I told if you lose weight, you don't have to take. She did it 83, now she's 76. So that 8-9% weight loss has already happened. Glucose control excellent now. So if there is a will, there is a way. So it's like that. So we should insist more on lifestyle changes. The thing is, we don't have time for that, and we feel they will not do it, and that's the reason these things are happening. She did it, and you find that it's all great. It's all coming down. Everything is improving. So any means, either from the drug or you do on your own. That's the best way, and that's what we have to tell. So that emphasis on lifestyle, a little bit 5 minutes extra will go a long way in not using these drugs.
In fact, this can be one of the best tools to tell patient that this is the time to really go into a serious lifestyle change. And one
Yes,
of the most demonstrable thing,
right.
rest of the things, you have a fat, you have put on weight, people may not agree. You say there is a fat in the liver, boss, everybody is shaken, immediately they start getting noticed. Boss, kuch ho raha hai, lafda ho raha hai. So it's like, it's very important to work on it.
Thank you so much, sirs. We are uh, uh, we are at the end of our audience questions and answers, and it's 9:13. I believe we've had more than 1,500 logins,
Oh, good.
sir. And
Good.
having that actually at this point of time in the night is probably only because of the three esteemed speakers that we have, Professor Tivaskar, Professor Bantwal, and Professor Dr. Suhas Egandesa. I take this opportunity to thank each of our esteemed speakers. Professor Mangesh sir, Professor Bantwal sir, I mean, the way it was presented, the beauty was that the not just slides, it was clear takeaways for the audience. And I think that's what sticks with the audience. Dear audience, we thank you too for actually taking your valuable time.
And pairing their
And
dandiyas, boss, especially in
absolutely,
Bombay,
sir.
Gujarat,
During Navratri. Yes, sir.
pairing their dandiya ras, it is a great, great thing. And thank you for your love and affection, honestly.
At this point of time, but we're very sure that the takeaways from this webinar would ultimately empower you in your clinical practice with actual practical takeaways. We also thank Professor Suhas Egandesa for his wonderful snippets of practical clinical pearls that he has shared during the Q&A, along with, of course, Professor Mangesh Tivaskar sir and Professor Bantwal. Last but not the least, we also thank our technology partners, DocMode, for aiding in the very smooth streaming of this webinar. Thank you so much, dear sirs. It was an honor to host each and every one of you.
Thank you. Bye-bye.
Thank you,
Bye-bye.
Partha.
And of course,
Thank you, sir.
the
Thank
moderation.
you, Mangesh. Good night.
Thank you. Bye-bye.
Ganpati sir, thank you so much. Good
Bye-bye.
night.
Good night.
Thank
Good
you.
night, everybody.
Good night,
Take
sir.
care. Happy
Happy
Navratri,
Navratri to you
everybody.
guys.
Happy
Yeah,
Navratri
same.
to each and
Bye-bye.
every one of you.